I went off to the University of Teesside, and then I came back, sorry, to Singapore, where I went to the National Council of Social Services, and I worked for a special school. It was called MINDS, Movement for the Intellectually Disabled. It was a society for that. I worked for children from the ages of 4 to 18 years of age, and that's when I actually got introduced and worked very closely with the families and children with sensory processing disorder. Thank you, Amrish, for telling me there's no background noise now. And hi, Holy Spirit. Um, so what happened was, because it sparked my passion in that area for sensory processing dysfunction, I decided to further my knowledge, and that's how I ended up coming to the U.S. I went to University of Pittsburgh to do my post-professional master's, where there was just so much information. And I loved it here. There's so much research and so much opportunity to kind of specialize in different areas in sensory processing. And so I later on went to work at the University of Illinois, Chicago. And there I worked in the outpatient facility, mainly with this caseload with patients with sensory processing disorders, children with ADHD, autism. And I also worked in the high-risk clinic. The high-risk clinic were children who were premature babies. And so they had a variety of different issues, and some of them were also experiencing sensory processing. And that kind of led me to the research area of engaging in research and collaborating in research with I did research on my own, and I also collaborated with others in this topic area. I had the opportunity to also teach a guest lecture at the University of Illinois in this area as well. What I did after that was I continued and I did my post-professional doctorate at UIC, where I specialized in autism and sensory processing disorder. Along the way of gaining knowledge, I also did two fellowships. It's called the LEND Fellowship. It's a little, it's a load of words here. It's called the Leadership Education in Neurodevelopmental Disabilities, and with a focus on autism. It was a program through the Maternal and Child Health Program. It was a fantastic program for a year. I did it in 2006, where I engaged in listening to a lot of the latest research. I was able to work with people in the field, learn what was the latest techniques that they were using. Also, in 2006, I was very lucky to work with somebody who, the project that I was on was through an initiative through the CDC, where at that time in 2006, they were expanding the knowledge base on autism and trying to get it to be tested in all the clinics. So I would bring the brochures to most of the physicians' clinics. That was the First Step program, it was called. And then in 2012, I did the fellowship again because I thought it was such a fantastic fellowship. So I applied, I got in as a clinician this time. And again, there was breadth of knowledge, all the latest information, latest techniques, assessments that were conducted. What really piqued my interest was being a change agent and advocacy issues. And one of the things that we were taught in the program was to actually write a legislative brief. And we were able to present it in Capitol Hill. So we went to see the senators for Illinois, and we presented a brief. So I worked closely with a partner, and we presented a brief. What she and I worked on was working on a grant for individuals over the age of 21 with autism and getting service provision, because for those of you who know or families who have children with autism, by the time they hit 21, there are not many programs out there. So once school is done, there are not many programs out there. And so that was the drive to write that legislative brief and make it aware to the senators of, what our problems are in this population. So this kind of leads me now to why I formed Healing Synergy LLC. Really, the answer is because it's uniquely me, and I can offer treatments and provide resources to families the way that it really reflects me and best fits the patient's families. I do a lot of family-centered therapy, so I collaborate with the families very. Hi, Kim. I work very closely with the families, and with the families, I tailor individualized treatments. So that's how this got peaked. And I work as an adjunct professor with Winston-Salem State, and I provide treatment for the infant toddler program, what is called the CDSA, Child Developmental Services here. I have written a book, and I've also developed an e-course that is tailored to parents and caregivers. And so this came about from all the questions, concerns that parents have had over the years that I've worked with them. So I kind of pulled all of that together, and then I kind of sent out a survey question to families as well, families that I've known, and asked them, what are the other burning questions that you have? And so that's kind of what generated me to writing the book, and then also the e-course where I can answer questions as well. And you can save, the modules as well. I also have started a blog, and I hope to make it a useful resource for families. So I urge you to send me a question, a topic area that you may have a concern in, or you would like to know more information about, and I'll write it up in the blog, because I think that's the best way to answer your questions. And believe it or not, whenever someone asks a question, there'll be other families who can really benefit from it as well. So that, I think, will be the best way to serve you and the questions that you may have. So again, please send it to me in an email, or you can directly write to me via Instagram. Today I wanted to touch on the topic on feeding. And I bring this up as one of the major topics because from the workshops that I've conducted and families that I see, feeding is usually number one. And there's a good reason for that, because if a child doesn't eat, it does not only stress the child, from the child being malnutritioned and not getting the right diet to even dental care, but also stressing the whole family. And I've seen that because I've worked with the families, and so there are a couple of things you want to think about when we have a child with sensory processing issues. It is developmentally what has happened. So, as I mentioned, I work for the infant toddler program right now, and some of the babies were born a little prematurely. And so they may have had to do the nasal gastric tube or the GI tube. They may have had, a variety of different things that they had to go through with surgeries, and sometimes orally they have different issues. So I have to go in, I work with the families to do desensitization. So that could mean even with them not wanting to take a bottle of milk, right? So they're averse to having a nipple in their mouth, or having a sippy cup. They won't have a spoon in their mouth. And these kids are already about one year old or 2 years old, and they may have like a limitation of maybe 5 to 10 foods that they will eat. So working with that population, and also work with older children who have sensory issues, and we know kids with autism have a limited range, right? So let me talk about a question that usually comes up, like, why will he not eat this, right? Why would they not put this in the mouth? Couple of things. If the child has a sensory processing difficulty, usually I do an assessment, and one part of the assessment, great question, what makes a child a picky eater? Thanks, John. Well, with a picky eater is when they have a limited range of foods, right? And that can be based on sensory dysfunction as well. So they can have an oral aversion to certain kinds of foods. So different textures. They may only eat, unfortunately, you hear a lot that they only eat, say, nuggets or fries, and just limiting to that. And if you think about it, it's crunchier foods. So anything that's of smoother texture, like, for instance, like yogurt, they will not put it in their mouth. And if a child is not desensitized to those textures, you can kind of build up on it. So we have to go in and find out from the families what textured foods do they eat. And there's something called a vibrating a Z-Vibe. It's like a vibrating brush with different textures, and that's what I start kind of working around the face and in the mouth, to slowly start desensitizing the child, and also give techniques to the family to keep doing, so that you're kind of desensitizing or actually increasing awareness around the mouth and then desensitizing inside the mouth. So for some kids, you have two different problems. Some kids, there's no awareness, right? You could have food all over the mouth and they're not wiping it off, right? The problem with that is, if they are under aroused, is they may pocket food in the mouth, which is dangerous because they can go to sleep with food in their mouth and choke, right? Or they have things on their mouth and they are not working on like licking the food off their lip, like taking it off from the sides, and it just remains there. They're unaware of it. Like I said, I've had kids who are under responsive who pocket food in the mouth, and that is a huge issue because they can choke on it. So you want to build up awareness inside the mouth, right? You increase the awareness. Then you have the kids who are over responsive. The kids who are over responsive, or the oral aversion, is anything you bring in, they will gag and they will throw up. So you can't actually put anything in their mouth before they will throw up the food. And if you try to bring food close to their face, they will move away. So again, that is because they are over responsive to certain smells or textures. And what we need to do is actually go in and slowly desensitize the child. Again, when I talk about desensitizing, you do not want to pressure the child, even if the child is an infant or the child's older, because they will move away from you. And so when you start working with them, you want to make it fun and happy. You want to put the food out so that they can touch the food, they can play with the food. And you know what kids do when they are mashing the food on their tray? They will kind of bring it up to their mouth, and that's fine. These kids with sensory over responsiveness tend to look like they want to control things, and for good reason, because their sympathetic system is firing off, right? So they want to feel like they are in control. Let them be. Let them play with the food. You can kind of mash it up on the tray, so they play with that, and then they bring it up to their lip, because we all kind of touch our face at some point, and they'll touch the lip, and they slowly get used to the smell and the scent, and they start licking it off. We also use the Z-Vibe, like I talked about. That has different textures on the top, and so I usually let the child hold it, and I have my hand on the child's hand as I bring it closer to their lips. So I let them feel like they are in control, and I just kind of facilitate it, and they will put it first on their lip, and then it goes on to their teeth, and then slowly the next stage is in the mouth. And I always tell parents, you know what, let them be. If they bring it right up to the cheek or to the lip this session, that is great. That's a great first step, right? And so you kind of subsequently work through that. You work with first touching the lip, and then you add some food to it. Preferred foods first, so that they like it, and then they put it in. Once you get it in the mouth and on the tongue, you can start working on doing what's called kind of lateralization of the tongue, so that you're having curvature for the tongue, for sucking, and then the tongue can move to different sides of the mouth. You can do a lot of facilitation in the mouth. And then I start pairing it slowly in small increments with foods that may not be of preference. But first, again, I always let them play with the food so that they're used to the smell, they're used to the taste. And sometimes it may take a little longer for some kids than others, because each kid is an individual. So we work at their pace, but always promoting it, always leaving it there. And sometimes you can leave it on a plate, on another plate, on the side, so they can visually just look at it. They're already seeing it, they're having the smell, and that's fine. And slowly, gradually, you can kind of bring it onto the lab tray and work on desensitizing. I hope that that kind of answers your question. If you have any other burning questions, let me know right now. I'm going to give a few minutes to see if any of you have any other questions for me. So while talking about sensory aversion, we all don't eat every food, right? There's some foods that we don't really like. But for these kids with aversion, you know that because it's very exaggerated. So you know that they're not having these foods. There is there are different programs available. I would definitely tell you to please go see an occupational therapist to get an assessment done so that we can structure that for them and slowly help desensitize it with them. So while I talk about oral aversion, there are a few other things that you want to think about with your child. Does your child have high tone or does your child have a lower tone? Right? So if your child has a lower tone, and I've seen that with families where they go like, he will eat just for a while and then he'll just stop. And it's okay. If your child has lower tone, chewing can be hard, right? So you want to build up that in increments, right? Because you can't expect him to eat a 2-ounce jar of whatever because it's like a marathon if they've just started eating and they have low tone. So for a child with low tone and has some sensory issues, have smaller breaks for them. Break up the meal so that they eat a couple of spoonfuls and then give them a break so that they're not fatigued. Because if they're fatigued, they're going to fall asleep and they're not going to eat, right? So that couple of things to keep in mind. Always make it fun for them. Always let them hold the spoon and you have your hand over it so they always feel they're in control. I always tell parents it's like going to see a dentist, right? How many of us like the dentist putting stuff in their mouth, right? Putting stuff in your own mouth. So just like that, if you have a child with sensory issues, I let them hold the spoon, I let them hold the Z-Vibe, and I have my hand over it. And hi, I think we're back again. I am so sorry about the technical difficulties I'm having right now. I think I talked about, I think I'm back. Can you give me a thumbs up if you can see me? Hi there, can you see me? Can you give me a thumbs up? Let me know if you can see me. It says, okay. Let me double check that you can see me. Keeps reconnecting. At this point, if you have any questions, you can ask me right now. I'll be happy to answer those questions. So again, just to reiterate about oral aversion or food issues, you want to introduce the food slowly, make it really fun. So you can get the child to first kiss the food or touch the lip. Then maybe the next day for the child to just lick the food. And if the child takes a bite on a spoon or a food, one bite, give them the biggest applaud. Make it a very big deal for them. And you want to reward the child with big, huge praises for them. That's going to be a huge incentive for them. Again, make sure you're allowing them to play with the food and slowly, gradually make them move to the mouth, working at their pace. The other issue I would like to also address is parents going to a restaurant, and you find a lot of these parents saying, I haven't gone to a restaurant for a long time, or I'm not joining like a family gathering. What holidays is supposed to be a fun time, like Christmas or Thanksgiving, but that's when they feel, no, I just cannot have my child around too many people. And I'll tell you why. If that's something you're experiencing, think about it. If a child has sensory processing difficulties, it's not just oral for them, for some of these kids who may be able to eat when they're alone, right? But if you bring them to a restaurant and they have auditory difficulties, think about the sounds, right? People eating at another table, we don't hear it because we're not, hypersensitive to it, but just the cutlery hitting each other is nerve-wracking for them. It's like scratching a chalkboard for them. So for kids like that, you can, we teach a lot of self-management skills, so they can actually bring the noise-canceling headphones, right? Once they know that they can manage those sounds, actually it's a simple solution, and it becomes a whole lot easier for them. And actually getting foods that they like. For kids with autism, we can also write social stories for them, what to expect when you go to a restaurant. There's going to be a lot of people. There's going to be a lot more people in close proximity. There's going to be a lot of sounds or noise, and that's okay because we have the headphones, right? We can always take the headphones, and I can guarantee you, a couple of kids that I have treated before, they will tell you, I think I need my headphones right now. And that includes even going to the restroom because of the flushing, right? So there are many different things we can think about, even just surrounding feeding or sitting too close to someone, right? If you sit on a chair, it's different than sitting on a bench because you're very close. So know your child, know what their needs are. And if you need me to help out with that, I'll be more than happy. So just again, send me an email, send me a question. I'll be really happy to help you through. I apologize again for all the technical difficulties. I know some of you have been have been here since 7. So I'm going to keep this for an hour. I want to thank you all so much for joining me and on my first discussion. And if you want me to touch on any other topic for the next time, let me know. Send me an email and connect with me directly at any time. Again, thank you so much for joining this discussion today. Once again, if there is any questions, let me know. Otherwise, I'll see you at the next discussion. Thank you very much.